Kissing nevus of the eyelids occur characteristically in both upper and lower eyelids, appearing in continuity when the lids are closed. They are also called divided eyelid nevus, split ocular nevus, or panda. They do not grow in size, but as the child grows, they may become darker and nodular. Chances of them becoming malignant are there, but has not been reported due to rarity. They do produce secondary problems in vision, amblyopia, keratopathy, but the main concern for patients is cosmetic. I have had the opportunity to reconstruct 6 cases during 1995 to 2015. The treatment consisted of excision of the entire lesion and reconstruction. The lesions involved the entire skin and dermis. There was no extension to the orbicularis and tarsus, though the lid margin was affected. Results were functionally and aesthetically acceptable to the patients. Follow-up of the cases was for 3 years. No malignant transformation was seen. Pathogenesis of the kissing nevus may be explained by embryological development of the eyelids. The lids appear as ectodermal folds from the 6th week of fetal development, and they grow over the cornea and unite by 12th to 14th week. They remain closed till 27th week when they separate. The melanocyte migration from the neural crest occurs during 12th to 14th week to colonize the epidermis when the lids are fused. Once the lids separate after 28th week, the kissing nature of the nevus becomes obvious. The surface of the lesions are velvety, nodular and darker in color. The lid margin is involved with wart-like excrescences and thickened. The pigmentation and velvety appearance extends on the posterior lamellar side for about 1 to 2 mm below the lid margin, but does not extend into the conjunctiva. The sharp border of the lid on the posterior side is rounded and nodular. Below the pigmentation, the tarsus and conjunctiva are normal in color. It involves the medial half of eyelid in this case. The patient felt that it was growing and had irritation. The cilia in the affected part of the lid margin were sparse. They are thicker and arranged irregularly. But where the lid is bereft of pigmentation, it is normal. Here you can see the patient after reconstruction. How did I do it? Excision of the nevus involving the lid margin, raised tarsoconjunctival flap from both lids. They were advanced suturing of the tarsoconjunctival flaps to create tarsorrhaphy. Skin advancement from both. In this case, excision of the lid margin and anterior lamella was done. The epidermis and dermis is excised. This is done with a radiofrequency cautery or with a knife. Once the lid margin has been excised, the TC flap advanced from both lids and a tarsorrhaphy is done. Punctum is preserved, anterior lamella advancement flap, and separation after 6 weeks. And here you can see after 6 weeks separation how the lid looks like. A video management is excision of the entire lesion, including the involved lid margin, which included tarsus with conjunctiva. Excision is done with radiofrequency cautery. The nevus along with the dermis is excised. The muscle layer is not involved. Reconstruction is done. The tarsus with conjunctiva from the remaining part of the lids are advanced as a tarsoconjunctival flap and sutured with absorbable sutures material 60 vicryl, leaving a small opening in the medial and the lateral ends of the lid. This is the dorsal tarsorrhaphy. Raw area over the orbicularis muscle on the lids and periorbital area is covered with a split skin or full thickness skin graft. Here you see a patient of a kissing nevus, excision and reconstruction done. Release of the tarsorrhaphy is done after 6 weeks. This is done so that skin graft would not get contracted. Some ptosis is expected. Another case of a kissing nevus, excision and reconstruction. Follow-up after 1 year, the skin graft should be massaged regularly and silicone gel sheet is placed to reduce the contracture. A child who had come during early period when only the lower eyelid, only a partial excision and FTSG was done in the childhood. Excision of the entire lesion with lid margin, full thickness skin graft from upper arm was done at a later stage. Advancement of TC flap and tarsorrhaphy separation after 6 weeks. A case of a kissing nevus which was partially excised elsewhere. It had resulted in ectropion of lower eyelid, laxity of the lower eyelid. Besides the excision, lateral canthoplasty was done to correct the ectropion and elevate the eyelid. Here you can see the patient in whom the excision of the lid margin and anterior lamella was done, lateral canthoplasty and with excision done, advancement of tarsoconjunctival flap with tarsorrhaphy, split skin graft over the entire area, division of tarsorrhaphy after 6 weeks. False eyelashes were placed over the eyelid because there were no lashes in the reconstructed eyelid. A child with a kissing nevus, the excision was done totally. A split skin grafting was placed because it was a fairly large area. Advancement of tarsoconjunctival flap and total tarsorrhaphy, and after division you can see it is fairly acceptable. A nevus in the lateral third of eyelids, excision and full thickness skin grafting and tarsorrhaphy done to give a good cosmetic appearance. Kissing nevus of the eyelids are quite rare. They may grow slowly but do produce aesthetic problems. I have not seen any case showing malignancy. The color match may not be perfect, but it takes away the attention from the dark spot. This is a simple method done in a few cases. Thank you. For any doubts, you can contact me via this number.